Welcome back. We are now at the CAT lab number 4. The contralateral side is perfectly closed now. Gustavo is doing the skin suture and everything is finished on the lab number 1. On my right side, Dr. Fava and Silvina, Kevin and Claudio as technicians, Mariana from Edwards, and Alex here as a nurse, and Dr. Vivas as anesthesiology, and Dr. Murcarcel as echocardiography today. So Carlos has already done a contralateral access. We have crossover, but first we are going to present the case. Let's go. I forgotten Dr. Rodriguez, who is going to be also the digital moderator here. Let's move to the slides. Okay, could you move the Larco, si no, no veo? Okay, perfect. Okay, let's next. No, para allá. Okay, so this is an 88 years old male who presented with shortness of breath. He has a history of hypertension, dyslipidemia, and morbid obesity. He is not fragile and not futile, according to our team evaluation. Next. So the ACG is under normal renal syndrome. The previous ACG, I don't know how it's now, today. Is the same, the ACG? Okay. So the blood test is quite normal, nothing special about that. The body mass index is 37. The echo Doppler evaluation showed a preserved left ventricular ejection with a 15% of ejection fraction, hypertrophy with severe aortic stenosis, with an area of 0.9, with a gradient of 66 and 33, with a peak velocity of 4 meters per second. The coronary angiography was done in another center with, and it didn't show any significant lesions. Unfortunately, we don't have this angiography. Next. So according to with the core lab evaluation on the angio CT, it has an annulus of a diameter of 23.6 and 29.6 with a mean of 26, a perimeter of 85 and an area of 564. With the high ostiums, the right is at 19 and the left is at 16, but with a very significant angulation of 67 degrees. Next. This is the pictures of the annulus with the measures which were already mentioned. The SVOT is big. Excuse me. The sinus of Valsalva are big, with 36 and 37 and 32 millimeters in diameters. We can observe here some calcification at the top of the leaflets in the area of intracommissural. Next. So here the LVOT, which is almost similar to the annulus, I would say that is quite similar, with the sinotubular junction of 30 millimeters, no calcification there. Next. This is also good. And here we observe the ascending aorta with the 31 millimeters in diameter. And on the right of your panel on the slide, you can observe quite significant calcification, not especially on the leaflets, but in the middle part of each of the leaflets. Next. So here, once again, we can observe the measurements of the ostium heights. 16 and 19, as it was already mentioned, some calcification on the annulus on the non-cuspid area with some little protrusion into the SVOT. Not that big, but this we are going to be careful with the over dilatation of this. Next. So this is the angulation, which was already referred, 67 degrees, as probably the main reason we have chosen a balloon expandable valve with a deflectable catheter for a better orientation in this angulated aorta. We observe a significant calcification of the mitral annulus. Next. So this is the implanter's view. I think you have written, Kevin, is right oblique 26 on caudal angulation of 43. So it's going to be very uncomfortable. So we might reach a near overlap at 20 and 35, just in case we cannot work at the original view. Next. These are the vascular access. I would say that they are more than acceptable, no significant tortuosity, some calcification on the ostium of the common iliac, left common iliac artery. Next. Diameter is okay, and here is the diameter of the left, but a little bit more tortuous artery. So we have chosen to go from the right side. That's why Carlos did the puncture here on the left, and he did crossover to the right where we are. We have the echo for the puncture. We are going to do echo and angio-guided puncture to put the sheath. Next. So the strategy in this patient was suggested TAVI. We are going to be percutaneous access, and once again we have chosen the balloon expandable TAVI or transcatheter heart valve. Next. So according to this instruction for use from Edwards, according to diameters and areas, we have selected a 29 device, but with the 29 we have calculated the oversizing. The oversizing at nominal with the nominal, it's going to be close to 15. So we have discussed it with Mariana in the morning, early in the morning. So we have decided to go with 29, but with 1 cc less. So with this 1 cc less, the 29 is going to be 11 oversizing. So I think this is a good option for starting. And in case we have a leakage or something like this, we can add some 1 or 2 cc more if they are necessary. Next. So this is our selection. Let's go to the lab. And maybe I can ask Dr. Mukasser, you have an evaluation or some images that you want to share? We can see the echo here.
Yes, hi everyone. Of course, I have already seen the patient. We have a patient with normal LV function, and the gradients, as previously described, were 69 and 46 with 4.15 of max velocity. So we have no effusion, and both ventricular functions are normal, LV and RV, and we have a mild mitral regurgitation.
Okay, so there is a good correlation with the gradients and the ventricular function observed before. Is that correct?
That's right.
Let's see here the groin. So now you can move the table or the arc. Let's see. Okay. So it is connected. Yes. So here I will try not to touch. That's why. This is an important observation. That's why sometimes doing an angio before is okay, not only the echo, because if you have branches, if you can avoid it, it's going to be okay, because if you destroy this branch, probably you have bleeding, not related with the suture, neither with the suture nor with the access, actually with this lateral branch. So let's see with the echo. You are not going to see the echo, probably más profundidad. Okay, let's see. We are too low, and there. Okay. It's too deep due to the morbid obesity of these patients, so we have to use everything, the echo and the angio, all together. So now, okay, it's not that easy with the echo due to the obesity. So now we are in, movete para tu lado, so you can have the echo. Dame un poco de luz, de arriba nomás. Okay. So to be honest, I feel some resistance as if it were some calcification there. I'm going to complete the heparinization now. Let me do some devulsion here. So once again, Dr. Rodriguez is on the monitor with the Slido to have questions that we can have it. Mostrame. Mostrame, hijo. So once again, it's important to be on the common femoral, very distal, just in case it's a very obese patient. In this patient, sometimes you have bleeding and you don't see on the surface because you have retroperitoneal, because they have a, movete para allá, important body surface. Okay, give me the shade wire. Give me a pro line. We will try with 1 pro line and 2 pro lines, but if we have problem, we use a pro star because I felt there is calcium on the anterior wall. So having the echo in advance, especially for all patients, sick patients, it's important because in some patients we have previous pericardial effusion. So in this situation, you know it from the beginning, and you are not worried if you have some effusion after the procedure. But if you don't know, when you finish the procedure, you have to stay in the lab for 45 minutes, 1 hour, waiting to see what is going on with this pericardial effusion. Because you don't know if it is, no, vamos a poner dos. You don't know if it is previous or after your TAVI case. We are going to use 2 devices. Usually we are now using only one with the complementary angiosyl. We are going to use 2 because it's complex access. It's an very old and obese patient. So which was the gradient, Juan?
60.
Similar, which was
69 and 46 gradient.
Okay. And what about the valve calcification? What is your appreciation on that?
So that might be a little subjective, but the valve is highly calcified.
Okay.
I don't see that the valve is more calcified in asymmetrically. It's like it's
Okay.
very symmetrical, the calcification.
Okay. So give me the sheet which was prepared. Okay, remember this sheet is an expandable sheet. Now it's 14, but then it goes up when you introduce the valve. Mariana, how you have already prepared the valve? Yes. So it's important to hold here because there is not a release. I will not rotate because I have some resistance there. No, not that high. Más abajo. I have some resistance here. I'm gonna enter now very smoothly. Okay, I'm gonna move para tu lado. Okay. Yes. So hold it. Give me another pair of glasses. The guantes. Gloves, no glasses. Excuse me. I regularly use 2, but now as I move from the lab 1 to lab 2, I didn't pull the 2. So now I want to fix the sheet. This is important because it's highly hydrophilic and it can move during deployment. Now we are going to put the facing on. Okay, got it. Perfect. Everything is here. No tenemos agüitas aquí. Okay, let me put the facing. So Why you have chosen, Carlos, pacing from here and not from the wire? ¿Tiene algo previo o no? Muéstrame. Sí. Muéstrame. Ah, okay. So this is a patient with left anterior hemi block. So we will put the pacing. It's late in the afternoon. We will try to be sure first. We have a good pacing during deployment, and then that the patient is protected overnight just in case. Okay. So Carlos is gonna connect the pacing. He's gonna test. Mariana is preparing the valve. Mariana, do you agree or not? Pre-dilated, no predilatar? Okay. We don't have to rush. We have plenty of time. So let's take the time for the valve preparation. No te apures. Because only we still have 45 minutes. Okay, we will try to cross the valve with the pigtail, but in case we need it, we have to prepare the Amplatz catheter with a straight wire. El marcapaso lo dejaste a cuánto? Okay. Limiting 40. Ayudaré a Mariana si necesita, Silvina. Okay. En la válvula, hijo. En la válvula. Let's try like this. If not, we change the strategy. But give me 1 or 2 minutes. I destroyed the wire. Okay. I have problem with the wire because I did something wrong and I destroyed the wire. So when we have significant calcification, we try to pre-dilate, but I think this is not going to be the case. Oblicua derecha. You see that in very tight stenosis, if you take, mostrame la punta de la guía. If you take some minutes with calm, you can cross the valve with a pigtail. So this is for here, yes. Now we are going to introduce the other pigtail. So we will measure the gradient. We can compare with the echo gradient. Then you can see, the projection, how uncomfortable it's going to be. Uncomfortable for sure, but how much uncomfortable. Muéstrame más arriba. ¿Ese es el campo coronario o qué campo es? No, poneme el otro. Let me flash. Okay. Okay, did you flash there? Okay, 0. Both zeros. Okay, Andres, no questions so far? Okay. Okay, here the gradient is not that high. It's like 50. Well, 66 was by echo. So it is okay. So here I have a configured wire, yes. I'm going to reshape it, trying to decrease the distal loop as much as I can, trying to make it smaller. Will you show the hemodynamics also with my hands so you can see the gradient? Okay. For some reason, they are not having monitors. Do you have a back? How you check the transmission? What is going on? Okay. So we have a loop in the wire. Now let's go to the projection. 26. Oh, great, great. Great, yes. Hemodynamic was shown. Okay, let's see. This is 29, so menos derecha. 20, ¿cuánto era? Let's see. 26, okay, here. And caudal 35, okay. It's not possible more. Okay. Show me the aorta. So, okay, we really have, listo, aceptar. We really have a very uncomfortable position. Remember that we deploy all the valves on right and left cusp overlap view. So the aorta is heavily angulated. So, sacale un poquito de caudal mientras trabajamos. Grabate la posición. Mariana, you ready? Okay, wait a minute. So we are going to introduce the wire. Oh, something is not going. A ver, Carlos. Okay. Probably I was kinking the pigtail. Show me the distal part of the pigtail. Okay, we have some extrasystoles. Carlos, keep going. Leave the wire distally. Be careful with the blood pressure, which is a little low. So we are waiting a little bit because the pressure is not okay. So now we are going with the valve. Vamos con la válvula. So position is checked. Okay. Mostrame que se vea la punta del introductor. No. Aquí. No, más arriba, no más arriba. No. Escúchame a mí. Ahí. Ok. Trabala ahí. Ok. Deja la guía venir un poco, no la tengas tanto. Oh, I had to make an effort here to introduce the valve. So it's important to have the view of the wire that is in position and also the set because we have to prepare the valve. So now the valve is out. No tome ahí. Okay. So now we unlock and now Carlos is gonna push the wire a little bit. I'm gonna retrieve the balloon. Now I'm gonna lock. I think it's okay. Push the wire a little bit. And now I will introduce the balloon into the valve. I'm gonna push the wire a little bit out of the sheet. There's a better position. And now I think it's in a good position. Do you agree, man? Okay, perfect. So let's move. Let's go up to see how we are moving on the aortic arc where we have significant curvature. I'm going to start to rotate here. So the device is moving. Okay. So now I have a flexion of the device. And now let me see if we can cross. I think we are cross. Let me test, very small test. Give me a second. Give me an unplugged wire. We have to reposition this. Tener atención a la presión. Está un poco baja y tengo que trabajar. Okay. I'm going to reposition the pigtail. As you can see, despite the tortuosity and the calcification, the valve moves okay and went in perfectly. So now we have to go to the working position, the valve a little bit deeper, probably there, but not too much. Let me see. Now I'm going to lock to retrieve the catheter, leaving the wire in the position. I'm going to lock. I'm going to check. Let's see, test. Okay, I think we are okay there. A little bit deep or no? So, Carlos, espera la presión, la caída de la presión, 180. Dale. Dale, 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 dale. Todo. 1, 2, 3, 4, 5. Marcapaso afuera. Okay, we decrease very slowly. Okay, give me a little bit where the position is. You see the position, I think it's perfect. Give me the unplugs. I like to do a little test with the device in, just in case I have to, if I have a huge perivalvular leak, I can inflate without moving too much. Please don't hesitate. We are waiting for your questions. I think the situation is okay. You have to put a little bit more. I will pull the device out. I will ask Dr. Mucarcel for testing and using my loop of the wire for retrieving the device. I'm going to take in some curve out, and the wire is causing some extra systoles. So let's put a little bit menos sublicua, menos caudal, so Dr. Mucarcel can check the echo.
So
We can show the echo with the wire still in place, and then we will do the angio.
okay. Let's take a look.
The problem we are having is that for this TAVI case, we have only taken 27 minutes. We still have 33 to do something. So the wire is in, but I still want to leave it just in case. The valve is, okay, let's you, Juan, describing.
Yes, the valve looks fully expanded. We have no leaks. Maybe just a dot. And then we have no pericardial effusion.
Okay, and what about the gradient?
Just a second.
Take your time. We have plenty of time. Looks nice, really nice.
Yes. That's
Oh,
the leak I was talking about.
Very small.
A small leak.
We can go a little, excuse me. a little bit up, but with the one abdominal, we are almost 15% oversizing. If the leak is not significant, I think we shouldn't do.
So there you have it, 16 and almost 8, the gradients.
Okay, okay. Let me, okay, no, keep you working.
Okay, so let me take a look. Just one little bit more, and I'll leave it.
Remember that it's a TTE, and that's despite this body configuration, the image is more than acceptable.
Yes. Yes, that's right. We as it's written, we may lose some leaks doing TE, but it's easier, simpler, and better for the patient.
Sure. Okay, let me check with Anshul. Let's see on the right caudal view. Probably there is okay. There, let's keep it there. So we have acceptable view there. We don't have to go to caudal, but I need to advance the pigtail with an amplas wire because we have a lot of tortuosity in the aortic arc. To be honest, while I was advancing the valve, I thought that I should have used a Landerquist, but finally it was not necessary. Uh, 20. Okay, let's see Ancho there. Oh, it's not. Oh, I think the outcome is perfect. Let's go with the pigtail. The position is really okay, probably 3-4 millimeters deep, no more. So, Carlos, you can keep retrieving the device.
No,
Leave the wire there. Just to retrieve with the pigtail. Remember, I don't like to pull the wires out. I know that some friends of mine used to do it, but I don't like it. I would rather like to stay in the safest way. Okay. So we'll check gradient from here, from hemodynamics, please. We can share with the colleagues. Que no se te baje la pressure. Sí. Let me flash there. Okay. Prepare the 6 French sheath. Prepare the size. Okay, let me check the zeros. Now better. Okay. No gradient at all. Very nice diastolic that configuration. The patient is still with 180 millimeters of systolic. So it's improving. So he needs some push for the next minutes. So, okay, give me light, put the arc in AP view. Let's go with the contralateral balloon. Or what do you have, a mammary catheter?
What do you want?
Give me the balloon, just in case. And 8 por 40, I think it's. Okay, I leave the wire here. So I pull this pigtail. I know this too early, So that's why I need questions from the panel, from the public, comments. I think first, my comment is I think we were exactly right using this balloon expandable with a deflectable sheath in such angulated aorta. It's good have been a very difficult positioning. We can do it. In some cases, we have to do it because I told you many times that here in Argentina, sometimes we have to use a device that health insurance push you to use it, and you cannot choose the device, cannot choose in the device. But in this patient, fortunately, we could, and I think the catheter, the deflectable catheter for positioning was really a good solution to get a better orientation of the valve and to have this positioning, which I think it was perfect. We don't have any kind of conduction disturbances so far. Hopefully none. Now we are trying to protect the iliac artery because this is a patient with some calcification. We are going to be very slow because we have plenty of time. And also diseased iliac artery or femoral artery. Móvete para aquí. So I will pull the sheath. Carlos is going to hold the groin. And then I'm going to introduce, okay, the 7th French sheath. Dr. Viva is going to revert the hyperonization. Patient doesn't have stents recently. That's why we retrieve the sheath with the introducing inside, so we prevent any damage of the artery while pulling. So yesterday I was watching a case from China, comprimí, Carlos, por favor, and I saw Dr. Samir Mehta there. So hopefully in the near future, we have Dr. Samir here in Buenos Aires. We can prepare a good asado for him, good cases, and hopefully he can enjoy also, as I saw him very happy in China. So Samir, you have to come. This is your house. So I think everything is okay. We don't have bleeding there, so we can pull the sheath out. We can push the knot a little bit more. Protamine is still going, it's not complete. And I will retrieve the wire now. Push the knot. Release, Carlos. As you can observe, the artery is really deep. We have a small oozing. So we can inflate for 2 minutes or 1 minute. Mostrame aquí. Saca la mano, Carlos. Here, 2 minutes. Put the clock. 2, 4, 6. So let me check if protamine is ongoing. Está pasando. Okay. So still under anticoagulation. So Claudio is asking me a very good question. If we would leave the wire on the right ventricle or no, the pacemaker, I think we don't need, because for 2 reasons. We don't have any kind of conduction disturbances so far. And also, the valve is in a very good position. It's not too deep. So I think we don't need it. So when we finish, we are going to retrieve everything. So now it's also a little bit hypertensive. So it's difficult to manage the drugs. So I think, Andres, you are not so convincing with the audience to asking you questions. Maybe you can ask some questions by yourself. That's a very nice question. With the 26, we did a lot of calculation. With the 26 and nominal, it was heavily undersized. with 3 extra cc's, we were like close to 10, but not more. And so if we have used the 26, we have to use a lot of additional. Okay, you can show the PowerPoint. Okay, let's go back to the PowerPoint while we wait for an additional 30 seconds. There, perfect. You see, with the 26, with 3 extra cc, the oversizing was 4. With 4 extra cc is perfect. It was 8. So that's where we have chosen 29. But as you can observe there on the PowerPoint, at nominal, it was a little bit oversized. That's why we decided to go 1 cc less, which is not that common. We rather use a smaller valve with extra cc's instead of going a little bit under nominal. But this was the case that we had to choose 1, and I think we were right going with the 29. But this is, I mean, the solution. Remember that if we have used self-expandable valve, we should have used the 34, which is also more difficult to position in such angulated aorta. You can reach it, but for the deployment in this angulated aorta, you have to go probably 1 or 2 millimeters above from the non-coronary cusp to get a good position on the left. This is challenging because if afterwards you have to post-dilate, the valve would be in a difficult position. So you can deflate. Okay. So now we are going to check. Let's see. Carlos, you have bleeding there? No, no bleeding at all. No hematoma, no bleeding, everything okay. It's clean. Perfect, let's check. Inyectó un poquito. Okay. It's a huge artery. And you see, we are very close between one and the other branch. We still have some use in there. Maybe you can hold it a little. We are going to close, but anyway, we are going to hold a little bit the groin for some minutes. Move here. I'm gonna close. Yes, thank you. Okay, this is Edwards balloon expandable valve. In Argentina, there are 2 balloon expandable. Of course, Edwards is the valve with more experience around the world. This is the valve that we more frequently use when we have to use balloon expandables. So give me the suture. And, oh, sorry. So this is an old patient, but another question would be how to choose a valve in a young patient. So in young patients, in my opinion, beyond the anatomy, you might decide between self or balloon expandable, but you have to use valves or transcatheter heart valves with the longest follow-up that we have so far. Because durability is the limitation for younger patients. In this patient, we should not use valves without any long experience or the longest we have so far. Okay, cortalo. So give me an angioseal. I'm gonna close contralaterally while Carlitos is gonna hold here for some minutes. I first remember to pull the wire and then the balloon because you can damage the carrefour. Please ask to us a little more questions. El angioseal 8. The other question for this case would be why to use right and left cast overlap view, which is not on the extraction for use FM use for Edwards. Well, in my opinion, this is the best projection. If we have doubt, we can control on the left or the regular coplanar 3 cusp view. But why I rather like this because this is the projection where you can observe better, which is the depth of the valve inside the LVOT. This is something that we learn with self-expandable, and we extrapolate to all other valves. Probably somebody don't agree with me, but well, that's good. That's life. We are not always agree about everything. So I'm very sorry because we couldn't have two TAVI cases today, as Samir asked us. Hold it a little bit. But I think we have two interesting cases, the IVAR case and this TAVI case. So if we don't have more questions, I don't like to speak because we have to fulfill the time. So let me check if we have any additional question. Okay, no questions so far. So probably somebody would also say that they are not using contralateral access. We still use it. I rather like it. I met some colleagues from Cleveland. They say that they are using the punction below, the same strategies I use for EVARs. But here for TVAR, we are still using the contralateral. But I think going from below is for patients where you don't have contralateral access, or when you have a problem that you cannot fix it from contralateral side, function below is a good solution. In the emergency, it's very difficult, but during, as elective, when you do it from the very beginning, it's a very good solution because it's very easy if you leave just only the wire to hold the SFA. It's very easy to fix this puncture. If you put an introducer, well, then it's a complication to hold it because compression is not probably enough. To use a closure device could occlude the artery because the artery is not that big. So this is not ideal, but just for protections in the emergency, you can have the wire, you can put an introducer, you can put a proximal balloon to the bleeding, and then you can decide what to do. It's like calling the surgeon, put a stent graft or whatever the solution you are going to select for this special situation. Well, with that, I would like to say bye to everybody. Thank you so much. And I will see you next week. Bye-bye. Wait.
Thank you, guys.
You can play the video so far. It's okay?